tattooing practiced long before the Christian era. In the practice of ophthalmology, sometimes it is not possible to restore vision in a patient. In such occasions where one has to cosmetically rehabilitate a patient, for example in cases of a blind eye with corneal opacity, the simple answer is tattooing. However, many ophthalmologists do not practice tattooing mainly for two reasons. Firstly, due to the non-availability of a suitable chemical, and secondly, the available pigments are irritants to the eye. The eye may remain inflamed following the procedure, and the corneal epithelium doesn't remain stable over the pigment. Hence, the ideal pigment would be one which is inert and easily available. With this background, I wish to draw your attention to Dr. Vikas Mahatme's pigment for tattooing. This pigment is neither water soluble nor lipid soluble. We tried this pigment on blind eyes, especially those who were willing to get their eyes enucleated afterwards. It was tried in patients with corneal opacity and the results were beyond expectation. Different techniques for tattooing are used for different types of corneal opacities. Let us see the first technique of multiple needle puncture. This is used in opacities which are superficial and not dense like nebular and macular grade corneal opacities. This involves the spreading of the pigment over the opacity. Multiple needle punctures are then made in such a way that the pigment penetrates deeper, but there should be no perforation. So, the needle should be oblique and move in different directions, but it should not go beyond the superficial 1/3 of the cornea. Let us now see the lamellar resection technique for tattooing. This is used if the opacity is dense and the superficial epithelium is transparent. We make a 3 mm wide linear incision up to the superficial 1/3 of the cornea at one edge of the corneal opacity. Lamellar dissection is then performed using a crescent blade. Hyaluronidase is injected below this flap and this creates a proper plane of cleavage. Once hyaluronidase is injected, the separation becomes easier with a blunt instrument like an iris repositor. After this, the pigment is spread between the superficial and deep corneal lamellae. This incision is then sutured with 9-0 nylon suture. Let's now move on to the lamellar graft technique for tattooing. It is adopted when the opacity is superficial and deep. We scrape off the corneal epithelium over the opacity. If the opacity involves the whole area of the cornea, make a partial thickness incision in a circular fashion so as to separate the stem cells and the conjunctiva. Then take a lamellar graft of the superficial 1/3 thickness of a glycerol preserved cornea. Tuck this graft below the stem cells and conjunctiva. If the opacity is small but dense and superficial, then tuck the graft as in epikeratofakia. Once this is done, suturing is performed using 9-0 nylon suture. But before tying the knots, the tattooing pigment is first spread between the graft and the recipient bed and then knots are tied. If the cornea has multiple forms of opacities, like central dense and peripheral nebular superficial opacity, then a combination of procedures can be adopted, like the central dense opacity can be tattooed using lamellar dissection and the peripheral superficial opacity can be tattooed using multiple needle puncture technique.